Good afternoon. Now we start the another session on vitreoretinal diseases, part 1. And with me is co-chairperson Dr. Ashish.
Hello, sir.
Dr. Priyanka Garg. Priyank Garg. Dr. Avdesh. Dr. Manisha. Dr. Hanspal Bhinder. He's here.
No, he's not there.
No, he's not there. And Dr. Gagan Bhatia. So I think the most important thing is that you must keep your time so that we can finish all the cases in time, and the discussion time can also be there. And we actually have a very expert panel so that we can take advantage of all these expert people. So the first one is Dr. Kamaljeet Harjot Madan. Is he here or not? Yes, you can come please. And she will be basically speaking on development of a predictive model for anatomical closure of macular hole.
I also request if the second presenter can come on the other dais, ready, Dr.
Yes.
Soumya Singh.
Correct. And one thing is that any presenter who comes on the dais, please introduce yourself first.
Start.
Audio visual, please. Audio visual.
यहीं पे हो नहीं रहा. It's not moving. ठीक. Good afternoon, everyone. I shall be discussing development of a predictive model for anatomical closure of macular hole with no financial disclosures.
Madam, please, you can introduce yourself.
Okay. Sorry, sir. I am Dr. Kamaljeet Harjot Madan. I am working as a VR surgeon in Tendai Hospital, Jalandhar. Macular hole was first described by Knapp in 1869 and classified into 4 stages by Gas. And vitrectomy was first of all described by Kelly and Wendell for macular hole with success rate of 58%. The causes of macular hole could be idiopathic, trauma, pathological myopia or VFT. 4 stages has been described by Gas. In stage 1, there is a yellow spot or ring formation. In stage 2, the small full thickness macular hole size is less than 400 microns. In stage 3 and 4, there is just difference of PVD. And surgical principles include removal of the vitreous, posterior hyaloid, ERM, ILM, and gas tamponade. We did a retrospective study in our center. We studied 107 eyes of 107 patients who underwent vitrectomy for macular hole. And surgical procedure was done in them with gas tamponade. And we recorded best corrected visual acuity, fundus photo, and OCT. OCT parameters measured were stage of the macular hole, height, base diameter, minimal diameter, macular hole index, diameter hole index, fractional hole index, and hole form factor. These are the various OCT parameters. And we observed that the mean age of the patient was 63.2 years. More females were there. There were 71 females, and the mean follow-up of the study was 9.2 months. And mostly patients, 71 patients, they had the grade 4 macular hole. And the visual acuity improved from 636 to 618 post-operatively. And 101 patients, they had the type 1 closure rate. And few complications were seen. From this study, we observed that if macular hole index is less than 0.3 or from 0.3 to 0.35, if we do the conventional procedure, the hole remains open. And if we do ILM flap, the hole was closed post-operatively. And if the MHI is less than, more than 0.35, even if we do the conventional procedure, the hole was closed. And in tractional hole index, we observed that if it is less than 0.6, and if we do conventional procedure, the hole remained open post-operatively. And in the hole form factor and diameter hole index, we didn't observe any relevant association. Even if we do ILM flap or conventional procedure, the hole was closed. So based on our results, we developed a very simple predictive model which indicates that tractional hole index and macular hole indices, they have strong correlation with surgical outcome. If MHI is less than 0.35 and THI is less than 0.6, they indicate poor anatomical closure and they need ILM flap. So based on this simple model, we did a small prospective study. Though it was a small number of patients, they were just 31. 4 patients, they had MHI less than 0.3, and 7 patients, they had THI less than 0.6. ILM flap was done in all the patients, and rest of the 20 patients, they underwent conventional surgery. So we observed type 1 closure in all the patients. So to conclude, ILM flap is a promising addition in the armamentarium of VR surgeon. And if macular hole index is less than 0.35 and tractional hole index is less than 0.6, patients need inverted flap procedure. Thank you.
In your study, in the prospective part of the study, it is just one side of the cases. The people who have more index, you have not presented.
In the prospective study,
Yeah.
yes, there was small number of patients based on that simple model. We just tried to see whether this study model is successful
But
or
you
not.
took only patients who had less than 0.35, not more than 0.35.
The rest of the 20 patients, they had more than, in which we did conventional procedure.
Okay.
Only 11 patients, they were there.
Fine.
But this model was instituted on a particular machine because the retrospective data is a huge data. So I don't think it was on the same machine, right? Could not be. So
No, it was same machine.
The
It
same
was
machine.
Octa. It was
Okay.
Octa.
Now I request Dr. Samya Singh to start her presentation.
Good afternoon, everyone. This is Dr. Samya Singh, and I'm here to present my novel grading system after successful macular hole surgery, which is based on ELM and EZ restoration. Macular hole is treated surgically by 3-port pars plana vitrectomy combined with gas or air tamponade with or without ILM peeling. Successful macular hole surgery is followed by sequential restoration of ELM and EZ. The ELM is defined as junctional complex between glial Muller cells and photoreceptor cells, which serves as a barrier against macromolecules. EZ clinically defines photoreceptor integrity and is rich in mitochondria. Visual outcome after macular hole closure is significantly better in eyes with restored EZ. The aim of the study was to develop a novel ELM and EZ restoration-based grading system for successful macular hole surgery and also to evaluate the EZ as a structural biomarker for final visual outcome. It was a tertiary care center-based retrospective study in which 34 consecutive cases of successful macular hole surgery were deployed. SD-OCT imaging analysis was performed on preoperative and postoperative data of week 1, 4, 12, and 24 respectively. Sequential measurements of macular hole size, ELM, and EZ were performed using the caliper function of OCT machine. Macular hole was graded as grade 0, in which there was persistence of ELM and EZ defect. The best corrected visual acuity in this case was 1.13 plus minus 0.19 standard deviation. Grade 1, in which there was partial or complete restoration of ELM with shortening of EZ defect. The best corrected visual acuity in this group was 0.59 plus minus 0.09 standard deviation. And grade 2, in which there was complete restoration of ELM and EZ. The best corrected visual acuity in this case was 0.26 plus minus 0.06 standard deviation. The results table here shows that as we go from grade 0 to 2, the residual EZ defect decreases and the visual acuity consequently increases. The post-op vision and residual EZ defect have a statistically linear relationship, and the ROC curve analysis shows that post-op EZ is an excellent structural biomarker for visual outcome. The graph here shows the changes in ELM and EZ defect over time. As we can see, the size of the ELM defect is less than that of the EZ, showing that the restoration of the ELM precedes that of the EZ. Discussion. Adult mammalian retina has potential for regeneration. Muller glial cells proliferate and produce new neurons. Lee et al. In 2021 highlighted that follow-up duration minimum lineal diameter, inner retinal layer thickness were significantly associated with EZ recovery. Yang et al. In 2021 demonstrated that patients with smaller diameter of EZ disruption and higher EZ band reflectivity tend to have better best corrected visual acuity. Kitahata et al. In 2023 showed that patients in whom EZ was restored in the autologous retinal graft had greater improvement of the visual acuity. We thus concluded that the novel grading system is physician friendly, incorporates pathoanatomical aspects, and correlates well with visual outcome. During recovery, ELM restoration precedes that of EZ, and the ROC area under curve analysis shows that the residual EZ defect is an excellent structural biomarker for the final best corrected visual acuity after macular hole surgery. Thank you.
My next speaker.
Panel? Any questions from the panel? So, thank you. Please. And can we also have the next speaker ready on the next dais? Dr. Somak Mazumdar. Yeah.
So good afternoon, everybody. I am Sai Kiranmaya, consultant in Video Retina Services from Pushpagiri Eye Institute, Hyderabad. I am going to talk about role of ranibizumab biosimilar, that is Razumab, in sight-threatening retinopathy of prematurity. There are no financial interests. The aim of the study is to study the role of ranibizumab biosimilar, that is Razumab, in the treatment of sight-threatening ROP, and also to analyze the duration of regression of the disease after anti-VEGF injection, and to analyze the duration of reactivation of the disease. Coming to methods, it's a retrospective analysis. All the babies with zone 1 and zone 2 posterior sight-threatening ROP who were treated with half-adult dose of Razumab between January 22 to August 23 were included in the study. A hybrid model of optometrist plus retina specialist-based screening was employed. This flow chart shows the screening program where the screening was done at the tertiary eye care center and mostly at the NICUs or the SNCUs. And indirect ophthalmoscopy was used for screening by the retina specialist, and even screening was done by imaging, especially in the remote rural SNCUs which were present far in the rural areas. Coming to the results, 4,620 babies were screened during the study period. Among them, 103 babies had sight-threatening ROP. Among the 103 babies, 41 babies had zone 1 and zone 2 posterior disease who were treated with anti-VEGF, and the remaining were lasered. The babies treated with anti-VEGF were followed weekly. Coming to the regression, all the babies' regression was noted within 1 week, and follow-up, 5 babies expired, 2 babies were lost for follow-up, and 34 babies were followed. These are the pictures showing the pre-anti-VEGF picture where you can see the plus sign and the neovascular network at the junction of avascular vascular retina, and after a week the plus sign and the neovascular network completely regressed. This is another picture showing a large network of neovascularization which almost regressed within 1 week after the injection. These are some more pictures showing the regression of the disease. Coming to reactivation, 68 eyes of 34 babies who were followed, 6 eyes completely vascularized, and the remaining 62 eyes were lasered. Among the 62 eyes, 30 eyes were lasered before reactivation because of their remote rural domicile or their inability to follow up. The remaining 32 eyes of 16 babies, laser was done after reactivation. So this table shows the baseline characteristics of the 16 babies. You can see that almost all of the babies had aggressive type of ROP, and most of the babies had zone 1 disease, and the age of at which the injection was given was 6 weeks after birth. And this table shows the reactivation of the disease and duration of reactivation, and we can see that most of the reactivation was in zone 2 and mostly in zone 2A. So the time frame between the injection and the reactivation of ROP requiring laser ranged between 30 days to 76 days with a mean of 50 days, which is about 7 weeks, and most of the reactivation was seen between 6 to 8 weeks. So with this, a follow-up schedule was made. The first follow-up was within 1 week after the injection to look for regression and also the adverse effects after injection, and then it was 3 weeks, that is 1 month after the injection, and after that it was a 2-weekly follow-up. And intense monitoring was considered between 6 to 8 weeks post-injection, as reactivation was frequently noticed during this period. So So these are the pictures showing laser after anti-VEGF and after reactivation. This picture shows the aggressive type of ROP, and if laser was done directly without anti-VEGF, except for the central macular area, the whole retina would have been lasered, whereas with anti-VEGF, the functional retina preserved is more. So to conclude with, ranibizumab biosimilar is safe, effective and economical in treatment of zone 1 and zone 2 posterior sight-threatening ROP as an initial modality of management. Reactivation, which needs to be considered as a rule after anti-VEGF injection, occurred mostly between 6 to 8 weeks in most of the babies. The predictable reactivation timeline enables a more efficient follow-up scheduling, buys valuable time for the baby to recover from the risk factors, potentially improving the compliance and timely intervention. The sequential approach of anti-VEGF followed by rescue laser provides a better functional and anatomical outcomes. Thank you.
Very nice paper. I just wanted to ask you, like, we all realize the role of anti-VEGF. How do you think is your study proving the advantage or disadvantage over and above the other anti-VEGFs by using razumab?
Basically, it is economical compared to the others, and the biosimilar studies are not very much compared to the other molecules, and also we mainly concentrate on the follow-up schedule and the reactivation, because initially we were following weekly looking for the reactivation. By changing the follow-up schedule, because our babies or were coming from the remote areas, so the compliance was very low when we were asking them to come weekly. So by looking at the reactivation and the period at which the reactivation was occurring, we changed our follow-up schedule, which helped in improving the risk factor, improving the compliance of the parents bringing the babies.
Also, I had one more question just to add to Dr. Manisha's question. So, looking at the medical legal aspect with ROP, is biosimilars approved as such? I just wanted to know that.
It is DGCI approved.
No, for ROP.
It is DGCI approved for ROP.
It is approved.
It
It is approved.
Yes.
Approved for.
By DGCI, yeah.
Right.
Thank you.
Thank you.
Any questions for Dr. Soumya also? Anybody? Dr. Bhatia, you wanted to ask something? No,
It's fine.
it's okay.
Dr. Somak, please.
Good afternoon, everyone. I am Dr. Somak Majumdar from Barakpur Shai Hospitals. Now, my topic is macular massage, a different technique of secondary closure for failed to close macular holes. Now, the classic treatment for macular hole is vitrectomy with ILM peeling. A newer modification of inverted flap reposition technique was introduced in 2010, but primary closure may not be possible even after effective and sufficient ILM peeling with or without flap reposition. The average rate of hole closure failure after primary surgery is 13.5%. So the primary closure is basically dependent on hole base diameter, the minimum linear diameter or hole diameter, and the hole height. Various complex procedures are practiced to achieve a secondary closure like autologous grafting, amniotic membrane grafting, etc. These techniques are time consuming, requires a long learning curve and special instrumentations. In the current scenario, we tried a different and simple technique of secondary hole closure, the centripetal massaging of the macula. Retinal massage for macular hole was initially described as a co-procedure in primary surgery mostly. The goal was to avoid any complex technique to achieve secondary closure of failed to close macular hole and to yield better visual improvement. So, purpose of this study was to evaluate the efficacy of macular massage in failed to close macular holes and to observe the secondary closure rate of macular holes using the macular massage technique, avoiding any complex technique for a better visual improvement in those eyes. So, the method was, this was a 6 months prospective interventional study, 8 eyes of 8 patients included, durations of the persistent hole after primary surgery, more than 3 months were included, detailed evaluations of demographic parameters like age, gender, BCVA, IOP done pre and pre and post procedure, baseline and final BCVA with visual improvement noted in logMAR clinal decimal scale, EDI OCT with different open hole anatomical parameters observed like foveal status, whether there is atrophy or cystoid changes, presence of everted edges, base diameter and hole diameter. Surgery time also noted. 25 gauge system, 25 plus gauge, 3-port pars plana approach, centripetal macular massage given with malleable silicone tip cannula, Fluid-air exchange was completed in all cases with aspiration of maximum fluid through the hole. The classic prone position for 7 to 10 days was maintained. In the results, the mean age was 57.8 plus minus 23.8 years, with a slightly female preponderance. Secondary closure was achieved in 62.5%. The mean baseline BCVA was 0.8, mean post-procedure BCVA was 0.5, and the mean visual improvement was almost 2 lines, 1.9 plus minus 1.4, with a significant p-value of less than 0.002. The mean presenting base diameter was 1033.9, mean baseline hole diameter was 606.8, mean follow-up was 4 months, mean surgery time required was 6.8 minutes, and mean post-op central subfield thickness was noted 122.7. Everted edge was found in pre-procedure in 75% cases. Cystoid changes at hole margin was seen in 62.5. Neurosensory retinal atrophy seen in 37.5. Post-procedure cystoid changes were resolved in all eyes. Mild to moderate foveal atrophy was seen. These are the two images showing the type narrow V pattern closure with lost ellipsoid zone and neurosensory retinal atrophy. Another one is showing the same, showing the post-op type 1 or wide V pattern closure with disrupted ellipsoid zone integrity. Failed to close macular hole is a challenging situation. Non-closure can be seen even after good inverted flap technique with sufficient ILM rexis of 3 to 5 days diameter. We found that macular massage can lead to secondary closure of the open hole in almost 62% eyes, which is a quite encouraging result. The visual improvement appears as early as at 1 month, and the maximal visual gain achieved at 4 months was quite satisfactory, almost 2 lines. The previous studies shown its efficacy in primary closure, but the current study utilized macular massage as an alternate to complex secondary procedures for secondary hole closures only. 25 gauge malleable and less traumatizing silicon tip backflash needle used to relax the perifoveal neurosensory retina and approximate the hole edges. Submacular fluid aspirated through the hole during fluid air exchange as much as possible was done for a better tissue approximation. The centripetal massage perhaps relaxed the perihole tissue and migration of cells towards the edge. Aspiration of fluid obliterates the potential spaces. Our result is comparable to closure pattern described by the others, and pre-existing neurosensory atrophy or thinning significantly reduced the chance of hole closure. So to conclude, the present study concluded that macular massage is a safe, minimally invasive, easy to perform technique that avoids complexity surgical procedure for failed to close macular hole. It is a short learning curve with minimal instrumentation and potential of significant visual recovery. Thank you.
Dr. Somak.
Yes, Dr. Manisha.
So Dr. Somak, I would beg to differ a little, because before we had the ILM techniques, we used to all try to have the anatomical closure some way or the other, but the problem was that it never resulted in a visual improvement. Even if when you are using a soft tip cannula and you are actually massaging the retina, it surely does result in some kind of an RP atrophy and compromises the visual improvement.
Yes, sometimes, madam, this occurs.
Yeah, so in today's time, I think when we are talking of a free ILM flap, inverted ILM flap, and so many other ways, I would be a little hesitant in today's time to actually opt for this. Yes, it is going to result in an anatomical closure, but I am a little skeptical how much of a visual improvement.
Functional result may not be as good as like the other grafts procedures.
Right.
Yes, ma'am. Actually, this is the my cases are sample size is quite low, so I think I need some more cases to really evaluate the exact procedure, what is actually happening.
Sure.
Also, the second thing that I wanted to add was that in your cases, so when you did this second procedure, which I mean, I do agree to Dr. Manisha that, you know, aspirating from the hole and is something that we usually don't do now. The other thing is that you didn't restain any of these cases. I mean, did you try restaining and seeing whether there was any ILM left over there or something like that, or that procedure was totally like aborted by you?
No, sir. Actually, in the primary procedure, the whole ILM was sufficiently removed.
But I might be wrong, but the OCTs that you showed had a kind of a ERM and a frilly ERM over there,
Yeah,
which
there
was
could
present.
be some ERM may be there,
Yeah,
but
so
I think
then
ILM was not present there, because I stained before, in some cases I stained before the macular massage, and it showed basically at that zone there is no staining. That means that zone is basically devoid of ILM.
right. Thank you.
you. Dr. Anshul Chawla can come for the next presentation on this side. Yes, Dr. Reddy.
Yeah, good afternoon. I am Dr. Dipendra and I am the presenting author.
Okay.
I'll be discussing surgical technique for macular holes associated with epiretinal membranes and its correlation with the closure patterns. I think there are two relevant literature I'll just briefly show. I think this one actually speaks about poor results and unfavorable closure pattern in this subset of macular holes, although there are few reports challenging this. And this one actually speaks about that if you try to peel ERM, almost 60% of times you will end up peeling ILM also along with it. And this has influence on our surgical technique for this particular category of macular holes. So we decided let's analyze our own results and see what happens when we use different surgical techniques for macular holes associated with epiretinal membranes. And of course, the cases having good videos, pre-op OCT scans, clinical data were chosen. Surgery was fairly uniform for all these cases. 25-gauge surgery, SF6 was used for 90% of these patients. We used Rossi's updated classification to grade post-op closures. And we excluded all those cases which have a confounding factor which can influence closure patterns. So just to show that we could find three different types of techniques which were used for these cases. This was one where we would peel everything, ERM and ILM, and just not use any kind of flap, just like we used to do in pre-flap days. So this was technique number one. The second one was where again we are peeling both ERM and ILM together. You can see the patchy staining which tells us that there is an ERM. And we are using this both ERM and ILM as a flap, as a scaffold. And the third technique which we were using was, we were trying to remove the ERM and use only pure ILM as a flap. And this technique is more challenging, but we could do it in certain number of eyes as I will show in the results. So these were three different techniques used to manage these 22 eyes. And this is all demography. You can see MLD of 200 microns and 728 basal diameter. So they were heterogeneous group of macular holes. And as far as anatomical results go, we could get closure in 95% eyes. Only one eye didn't close. Visual acuity improved from 0.8 to 0.4 in this whole group. If we stratify them by different peeling techniques, we could do complete ILM peeling with no flap in 8 eyes, and we used some kind of flap in 14 eyes. And when we tried to compare the visual outcome, it was fairly comparable between both groups, complete peeling and flap groups. There was no statistical significant difference in change in visual acuity between these two groups. But the most important point of interest was type of closure. Now, where we didn't use any flap, we got type 1 closure in 100% eyes. But when we were using any kind of flap, the type 1 closure we could get only in 53% eyes. And when we tried to do further analysis, what we found was when we were using ERM flaps, almost 71% eyes ended up getting a type 2 unfavorable closure. And if we were using pure ILM flaps, 12.5% eyes only got type 2 closure. So ERM flaps were found to be much more notorious in getting an unfavorable closure. And another important learning what we had from this study is 63% of eyes, whenever we tried to peel ERM, we ended up getting no ILM left. So that means we had only two options. Either we use that ERM as a flap or we just go ahead with no flap technique. So this was again which we learned from this study. I'll just show some results. This was complete peeling, no flap. You can see good type 1 closure where ERM flap was used. Again, type 2 closure, ERM flap showing type 2 closure, inverted ERM flap showing type 2 closure, plain ILM flap giving a very good type A, type 1 closure. Again, here even after using a pure ILM flap, we got a reasonably good type 1 closure. And again, type 2 closure whenever, this was, even in ILM flap group, we got this. So I think the main conclusion which came out from our study was that ERM as a flap should be avoided whenever you have this macular hole with ERM. Thank you.
Thank you, Dr. Dipendra. Any questions from the audience?
Dr. Dipen, I wanted to ask you, how did you randomize your cases, that which technique you're going to apply in which case?
It was a retrospective study. So the choice of technique was surgeon's decision, and most of the times on-table decision. It was not even a pre-operative decision. So there is a bias. Yeah. But
Usually a
the
smaller
whole size
hole
was very well balanced between all the groups. When we did this analysis, baseline characteristics, size of holes, all other parameters were very well balanced between both groups.
But then there would be this thing, no, like if you, with a no flap technique, usually it would be in cases where there would be a smaller hole as compared to a type 2.
We didn't have that option. When you lose ILM, when you are peeling the ERM.
No, in those cases I understand, but the primary first two groups where there is no...
if I'm not allowed to go back, but the number of larger holes were equal in both the groups.
Okay.
So, thank you.
Yes, Dr. Aditya.
Yes.
Okay.
Next speaker on the other side, please.
Yeah, audio visual, please see this. Your clock is not working. The clock here. Yes, started. Okay, thank you. Yes, now you can start.
Very good afternoon to everyone. I'm Dr. Aditi Joshi. I am pleased to present our study on long-term surgical outcomes in stage 4 and stage 5 ROP. So ROP is a major cause of preventable blindness. Surgery remains the only treatment option for advanced cases of ROP, specifically stages 4 and 5. But what happens to these eyes in the long term, that's what we aim to evaluate. So the purpose of the study was to evaluate both anatomical and functional outcomes of surgical treatment of stage 4 and stage 5 ROP over a minimum follow-up period of 5 years. So this was a retrospective chart review conducted at our center over a 13-year period from 2006 to 2019. 6 different operating surgeons had performed these surgeries. We collected data on patient demographics, surgical details, final anatomical and visual outcomes. We classified anatomical success into 3 categories. Unconditional success was defined as a fully attached retina with an undistorted posterior pole, whereas conditional success included cases where the posterior pole was attached but still had some residual detachment or distortion. Failure was characterized as total retinal detachment or macular detachment. So a total of 84 eyes with average duration of follow-up of 9.27 years were included in our study. 63% were males, rest were females, 40% were bilateral cases. 61% of our sample size had a stage 4 ROP at the time of surgery, rest were all stage 5, while 40% of these eyes were pre-treated with laser, 17% were treated with a combination of a laser with injection anti-VEGF. In stage 4A ROP, the primary surgical approach was lens-sparing vitrectomy, followed by scleral buckle. For stage 5, majority, that is 31 out of the 33 eyes, underwent lensectomy with vitrectomy. Now, coming to the anatomical success, it's important to highlight that the eyes classified as unconditional success at 4 to 6 weeks post-operatively largely maintained their status at the last follow-up several years later. However, eyes which initially had conditional success in the early post-operative period were more likely to experience long-term failure over time. In stage 4A ROP, the anatomical success was achieved in over 95% of the cases at 4 to 6 weeks post-op, and this remained relatively stable at 88% at the final follow-up. However, in stage 5 ROP, the success rate declined significantly over time, dropping nearly to half in the long term. The p-value was also significant in these cases. Among cases with unconditional success, the stage 4B had the best logmark visual acuity, suggesting that vitrectomy may play a role in normalizing the posterior pole. In contrast, scleral buckle, which is primarily performed for stage 4A, may not offer the same advantage in posterior pole normalization. The visual acuity was also on expected lines, with stage 5 having the worst visual outcome. There are 3 eyes in stage 4A who had good anatomical result, but no functional vision due to comorbidities like optic atrophy and severe developmental delay. The best Snellen's visual acuity was 618 in stage 5 and 4B, while it was 69 in stage 4A. So we studied the long-term results in ROP since the success in the immediate post-operative period does not always sustain later in the age. The growth of the eye along with the growth of the child has a differing effect on the retina. Also, longer the duration of retinal detachment, greater is the retinal contracture. This issue was seen in stage 5 having nearly 50% chances of failure in the long term. Stage 4A and B had a better long-term stability post-surgery, mainly due to the fact that surgery is done quite earlier in life and the retinal thinning is not as much as in stage 5. Hence, the surgery for stage 4A should be done early to avoid progression to stage 5. So concluding remarks are stage 4A are amenable to buckle in significant number of cases. Stage 5 results are uniformly bad. Despite initial success, recurrence in stage 5 is an issue. However, even with 30% chance of anatomical success, it is worth an attempt, especially in bilateral situations. These are the limitations that it was a single center study, a small sample size with multiple operating surgeons. These are my references. Thank you.
Thank you. Dr. Manisha.
So thank you for the data that you've shared on ROP surgeries. I was just wondering, I mean, this is something we already know, that stage 4A, they do very well with the buckle, and stage 5, vitrectomy is the only choice, but the results are not. So I want to understand that after having done this analysis of your data, were there any additional observations that you made from the data?
These observations, ma'am, are very similar to some of the studies that have already been published. But this study has a 9-year average follow-up, which is not found so much in literature. Most of the studies are like 3 years or maximum up to 5 years. So 9 years is quite a long follow-up.
So if you had such a long-term follow-up, did you make any additional observations of a long-term follow-up of a ROP child who underwent a surgical intervention?
No new observation that we could get.
Thank you.
Thank you.
Achha, just I wanted to know for myself, supposing a child comes with stage 4A, 4B or stage 5, so what finally we should give the prognosis to the child? Whether we operate or we don't operate, because as she has said, even after 9 years, everything becomes same. So what we should...
I think, sir, stage 4A, they do very well with the buckle. And I think they are able to be at least having an ambulatory vision, if not better. But stage 5, we have seen that very few, even if initially the retina appears well attached, the visual prognosis is bad. And many of them will have a recurrent retinal detachment.
Half the cases in
Half
our
of the
study
cases,
had,
exactly.
over time they had a...
Yes. So I think the key is that, you know, you avoid a RD, do an early screening and manage them with anti-VEGFs and laser.
Thank you. Thank you.
So next speaker we have is Dr. Abhishek Desai.
Yes, sir.
So you are talking on effect of Nepafenac on choroidal thickness
Yes,
in
sir.
patients with acute
Central
CSCR.
serous, yeah.
Okay.
Dr. Manavi, please come on the other side also.
So good afternoon, everyone. Today I'll be talking on effect of Nepafenac 0.1% on choroidal thickness in patients with acute central serous chorioretinopathy, a pilot study. As we all know, the CSCR is a pachychoroid, part of pachychoroid spectrum of disease characterized by the thicker choroid and the serous detachment of the neurosensory retina. And it is well proven that NSAIDs, by inhibiting the cyclooxygenase enzymes, hastens the resorption of the subretinal fluid, but its effect on choroidal thickness in acute CSCR cases was unknown. So we thought of measuring that effect, whether it affects or not. So when we did the literature research, then we found that people have studied its effect on choroidal thickness post-cataract surgery cases where they found the rise in choroidal thickness in post-cataract surgery was lower in Nepafenac treated group as compared to non-Nepafenac treated group. And the other review article, they found that there is no significant effect on choroidal thickness of Nepafenac in normal patients. However, it has been observed that prostaglandin analogs are associated with rise in the choroidal thickness group. So our primary objective was to study its effect on choroidal thickness in acute CSCR cases, and secondary objective was to study its effect on base-corrected visual acuity and central macular thickness. So it was a prospective interventional study done in Sri Ganpati Netralaya, where the main inclusion criteria was the treatment naive acute idiopathic CSCR cases presenting within 3 months, and the exclusion criteria were the chronic CSCR cases, those who have received some treatment for it, and those who are sensitive to any component of the study medication or any known cause for CSCR. So after obtaining a written informed consents, subjects were recruited for this study and a thorough ocular examination was done. The central macular thickness and choroidal thickness was measured by performing the swept source OCT, that is top cone Triton. The choroidal thickness was measured subfoveally manually by measuring the distance between the outer border of the RP and the inner border of the sclera, and average or mean of the 3 readings was taken. Then the subjects or patients were started on Nepafenac 0.1% thrice daily, and the review was done at 1 month and the 3-month follow-up. Data was analyzed by using SPSS software. So when we compared the results, there was a sample of 50 patients where the males were the predominant and having the mean age of 37.6 years. When we compared the base-corrected visual acuity, it has been observed that there was a significant improvement statistically in base-corrected visual acuity for distance and near vision when we compared the data from first visit with the second with the third, and first with the third. Same is the case with the central macular thickness. Additionally, we also tried to see its correlation with the age, but there was no correlation between the age and the central macular thickness. That means the treatment yields effective improvement in central macular thickness in all age group. However, in subfoveal choroidal thickness measurement, there was a significant difference in the reduction of choroidal thickness on each follow-up and in between the 2 follow-ups. However, there was a negative correlation with respect to the age. That means the younger the patient, they have showed a more improvement in the choroidal thickness reduction than with the older age group. The 4 patients out of 50, they complained of burning and stinging reaction to the drug or medicine, which was later subsidized on its own, and no serious adverse events to the medication was seen. This was one of the images of one of the participant, where there was a significant reduction on subsequent visits in the subretinal fluid and the resorption of SRF and the subfoveal choroidal thickness. So it was the first of its kind observation where the Nepafenac proven a significant reduction in subfoveal choroidal thickness in CSCR, which is a part of the pachychoroid spectrum of diseases, having excellent safety profile. It was hypothesized that it was published earlier that PG analog are known to cause rise in the choroidal thickness, and it is being an anti-PG synthetase inhibitor, so it might reduce the choroidal thickness. So, but there are certain limitations like smaller sample size and long-term outcomes were not known, and there is no comparison group was there. And the chronic effects in complicated or chronic CSCR cases, we don't know yet. But there is still a lot of scope for the further research, like comparing the effectiveness of different NSAID molecules in CSCR cases. Also, in addition to choroidal thickness, we can consider measuring the choroidal vessel density or the choroidal vessel caliper measurement in future. Thank you. Thank you so much.
Dr. Desai, I just wanted to ask you, did you have a control group in this study?
No, actually, ma'am, the same question was raised in our ethics committee meeting, that there is no control group in this study. But then our statistician and pharmacologist, we sit together, and then we thought it's a pilot study and none of the study was published earlier. So if it is a first study, then you can go ahead without the control group as well. But study holds a stronger value if you add the control group. So we
Because you know, here we are dealing with with a disease which is known to have a spontaneous resolution.
yeah.
And actually, we have done a study at our center where we actually compared eplerenone, we compared rifampicin, and antioxidants, and all the three. It was a randomized study, and we actually found the antioxidant group did the best.
Yes.
You know, so and also we had a control group.
Yes.
So here, you know, we know that it is going to have a spontaneous resolution. So whether it is actually because of nepafenac or it is just a spontaneous, it's very difficult to really say.
Yes, that's true, ma'am. But that all studies were compared the subretinal fluid comparison. None of the study compared the choroidal thickness, and it is a part of pachychoroid spectrum of diseases. So we thought of comparing this on subsequent visits. But sure, we are in process of including comparative group also in future.
That's a nice idea, but only thing is that, you know, it is known that probably once the disease is active and you have an inactive, when you have resolution of fluid, the choroidal thickness does change. So I don't know whether it's really nepafenac working, because even with PHCR, we've already published this where the choroidal thickness is thickest as when the disease is active only at the area of the PHCR. So, and then once the PHCR resolves, the choroidal thickness also, you know, the difference between the subfoveal and the PHCR thickness is different. I mean, reduces, the difference reduces. So probably it's just, you know, the disease activity which is going down. So.
But it's very interesting. I hope to come up with some solution for our cases as well.
And we are planning to extrapolate these results to other pachychoroid spectrum diseases as well.
Maybe you can take the thickness of the other eye for the same patients at least.
Yeah, that
Thank
can
you.
also. Thank you so much.
So next we have Dr. Manvi. Yes, she'll be talking on the potential regulator of retinal integrity is PIWIL1. Okay.
Dr. Tasneem on the other side, please.
Good afternoon. I am here to present my findings on proteomics of macular hole, PVL1 as a potential regulator of retinal integrity. This work was done along with our collaborators from Department of Biochemistry and Molecular Biology at the University of Pondicherry. Let us have a quick overview of molecular biology. Inside the cell nucleus, the human DNA undergoes the process of transcription to give rise to the RNA. The messenger RNA codes for structural proteins, while the non-coding RNA performs various regulatory functions. One of these is the piRNA, which binds with the PV proteins, which further bind with different proteins in the cell to carry out various regulatory functions or influence their action. So piRNAs are small non-coding RNAs. They bind with PV proteins as called in Drosophila, and PV-like proteins in other species are known to silence transposons, are present in somatic cells, and were first time identified in ocular tissues by our collaborators. And they have shown dysregulated expression of PVL4 linked to retinoblastoma and diabetic retinopathy. So we propose in this study to investigate the potential role of PVL1, a member of the PV family of proteins, in the pathogenesis of macular hole. IEC approved this prospective study. Undilated vitreous samples were collected intraoperatively from macular hole patients. PVL1 expression was confirmed by immunoblotting, and protein interactions identified by liquid chromatography mass spectrometry. So the vitreous samples were cleared of debris, 10 samples pooled together, and these were then incubated with the PVL1 antibody and the IgG antibody, which serves as a negative control. This was then subjected to electrophoresis. The gel was stained with Kumasi brilliant blue. The protein bands were excised, destained, and then they underwent lysis to extract the protein. This was dried and stored at -20 degrees. This was then analyzed by liquid chromatography mass spectrometry to get the output or the resultant interactions. The PVL1 immunoprecipitation was validated by Western blot. And following the mass spectrometry analysis results, one of the interesting factors, the pigment epithelium derived factor, was again immunoprecipitated with PVL1 and subjected to Western blot to validate our results. So we saw that the PVL1 showed a very interesting interactome and had many novel binding factors which influence various functions in the ocular tissues. Samples from SFIL served as a control and had a distinct different interactome. So in the PVL1 proteome interactome, we saw neuronal proteins Calcitonin and spondin were enriched hits which are crucial for axonal branching, compartmentalization in neurogenesis, and they support nerve growth and repair. We saw cytoskeleton organization elements which are involved in neuronal repair. We identified anti-angiogenesis factor like pigment epithelium-derived factor and opticin, which regulate disease-related angiogenesis and enhance neuronal survival during stress. Calcium signaling elements, which are essential for neuronal transmission and crucial in axonal guidance and growth. Elements involved in protein trafficking, which regulate protein degradation synthesis. Apoptosis-related factors that maintain mitochondrial function, energy production, prevent unnecessary cell death, and regulate cell growth, division, and apoptosis. And factors involved in chromatin regulation, which balance transcription, help in identifying cell identity, regulate retinal development by controlling gene expression. So to conclude, PBL1 shows interaction with proteins that influence nerve growth and repair and neuronal transmission. These interactions possibly indicate recruitment of a neuronal repair mechanism in response to the tangential and anterior-posterior tractional forces that lead to the formation of a macular hole. PBL1 promotes neuronal recovery by aiding regeneration after injury or stress and could be a potential therapeutic target for management of macular hole. Thank you.
Yes, Dr. Bhatia.
Really excellent work, but I just want to know that in clinical practice, where do we stand with this, or where do you hope that this would go ultimately?
Yeah, so this is like a very, very preliminary kind of a biochemical analysis where we have identified that these factors are showing interaction with the PBL1 in patients with macular hole. So probably further exploration of this and being able to elucidate how their role goes, maybe in the future we could have some kind of an agent which used either intraoperatively or maybe like an injection where you can recruit these particular things and their interactions to help in healing. But this is a very preliminary finding and study.
Manvi, very nice study. I just wanted to ask you, did you check on any inflammatory mediators?
There were no inflammatory mediators in this, ma'am. I'm actually presenting one part of the study. The other part was the diabetic retinopathy. That's a poster over here. In those, we had inflammatory mediators, but we did not have inflammatory mediators here.
Thank you. Thanks.
Thank you. Thank you, everyone.
You are Dr. Suraya?
Yes, yes, sir.
Okay. So she is presenting analytical study of genetic polymorphisms of ROP, progression and regression.
Okay, so good afternoon, everyone. My study is on analytical study of genetic polymorphisms on retinopathy of prematurity, progression and regression. Conflict of interest nil, financial disclosure nil. And as we all know, ROP is an ophthalmological disease of abnormal retinal neovascularization in preterm babies. And we all know all preterm babies with the same risk factors not equally affected. Why this is so? That is the essence of this study. We all know the prevalence of blindness in children is 6.5 per 10,000 children, and ROP is the second leading cause of blindness. And in ROP, 86% spontaneous regression occurs. And what happens to the remaining subset? So that is the essence. So in genetic polymorphisms that occurs in ROP, which is the root cause for the ROP, is the background. And here, what happens in the genetic sequencing? There occurs inter-individual variation that leads into the alteration of the proteins in the genes and as well as the level of the protein products. That leads to the formation of ROP in progression or regression. So objective of the study is to analyze the genetic polymorphisms of VEGF 936TC, then angiotensin converting enzyme insertion deletion, tumor necrosis factor 308G and A, and glutathione S transferase protein 1 genes on ROP progression and regression. And methodology is, it is an analytical study, and we have analyzed 100 babies which come to our department, and the period was done as May 22 to December 2023, that is 1 year, and the inclusion criteria, mild, moderate, and severe ROP, that is according to the stages of ROP, according to IC ROP classification. And exclusion, we have excluded babies having ocular systemic anomalies and the babies on any drugs and mothers not willing to participate in the study. And methodology, we have divided the babies into two groups. One is ROP with progression and two is ROP with regression. And blood samples were collected and we have analyzed for the frequency of genetic polymorphisms. So the techniques used is for VEGF, we have used PCR with the restriction fragment length polymorphism, and these polymorphisms are digested with the restriction enzymes, and ACID is alone analyzed with PCR and ARMS PCR. And the demographic profile here shows the age group is averagely 39.24 weeks, and birth weight averagely 1.5, it is less than 1.5, and sex male it is about 51 and female babies 49, and babies in progression is 34% and regression 66%. And when we analyze the stages of ROP, the stage 1 ROP babies accounted for 37%, followed by stage 2, then followed by stage 3, and aggressive posterior pole ROP accounted for 4%. And these are the allele and genotypic frequencies analyzed, and here the p-value had a borderline statistical significance only for anti-VEGF gene, okay? And correlation between stages and genetic polymorphism showed after reducing the confounding factors, the p-value came to be significant for this VEGF gene, and also ACE insertion deletion gene. So you can see here for the ACE insertion deletion polymorphism, the p-value came to around 0.05. And for VEGF gene, the p-value was 0.03. So the analysis results ultimately was the ACE insertion deletion polymorphisms was significantly noted in regressing ROP babies, and VEGF gene was significantly noted in progressing babies, and no statistical differences were found in the TNF alpha polymorphisms and glutathione S transferase gene polymorphisms. So comparison with previous studies, and in Saudi Arabia and Turkish Kuwaiti peoples, they have done previous studies. And in these previous studies, the Kuwaiti and Turkish study showed a ACID polymorphism and ROP risk regression. And Chinese study, there was a significant association between TNF and VEGF polymorphisms. And it was the one of the South Indian study, first of all Indian study we have done. And here we reported an association between ACID polymorphism and regressing ROP, and VEGF polymorphism with progressing ROP. And only limitation is our sample size. We have done a 100 baby study. It was done as a pilot study, and the ultimate conclusion of the study is actually we have to guide the development of the targeted and early treatment for infants at the risk of progressing ROP and thereby preventing blindness. Thank you, sir.
Thank you so much. Dr. Manisha?
Okay, so I just wanted to know that how do you get genetic testing done for so many people, though you call it limited,
Sir,
but...
Actually, we are doing a ROP screening for nearly 1,300 babies per year, sir. And we have diagnosed nearly 130 babies, and we have get consent from our ethical committee, and we are collecting blood samples from them, sir, and consent from them. And we have medical research unit in our medical college. And
but the concerns from the parents for genetic testing
yes, sir, we
is
get
not a problem.
consent from them, but not from the parents. We get consent from the parents. We take blood samples from the babies and we send to the lab, sir.
Right.
So based on your study, in future, we will be able to predict how the progression of ROP is
Yes,
going to
ma'am.
be by doing a blood testing.
Yes, ma'am.
That will be something
Yes,
interesting.
ma'am. Actually, we have more studies on management, but prevention, we have only limited studies. That too, we have meta-analytical studies only in the Indian population. In Indian population, we don't have a genetical study for prevention.
No, but prevention would be means parent sample or child sample?
Child sample, we have analyzed child
As
samples,
born-
sir.
as-
But we can proceed with the patient, mothers also we can do, sir.
Right.
Thank you
Thank
so
you.
much.
Thank you, ma'am. Thank you, sir.
You are Dr. Sumit? Yes. Okay, you can present your presentation.
Dr. Kanika on the other side, please.
Can I have the slides, please? Okay, so
very good afternoon. So I'll be presenting on the topic, I am Dr. Sumit Randir Singh. I'll be presenting on the topic delayed rhegmatogenous retinal detachment post-macular surgery, a multicentric study. So we all know that macular surgeries for indications such as full thickness macular hole and ERM represent up to a quarter of total retinal surgeries. Rhegmatogenous retinal detachments post-macular surgeries usually necessitates a resurgery, and it can happen in approximately 1 to 3% of the patients. Considering the rarity of delayed RRD post-macular surgery, there is very limited knowledge about the possible causes, clinical features and the outcomes of these patients. Therefore, we undertook this study, and here we report the anatomical and the visual outcomes of eyes who developed delayed RRD post-macular surgeries. So our inclusion criteria was the patients who developed RD post at least 3 months after macular surgeries. So we did an anatomical as well as functional assessment in which we studied the best corrected visual acuity at pre and post operative stage. We studied the indications and the details of both the macular as well as the RRD surgery, the time interval from macular surgeries to RRD diagnosis, the location, extent of RRD and the nature of the retinal break, and the post-op outcomes defined as the anatomical as well as functional success. So these are some of the results. We noted that delayed rhegmatogenous retinal detachment happened in 16 out of 2,906 eyes who underwent macular surgeries. So this is a prevalence rate of 0.55%, and this happened after a mean period of 8.4 months. Intraoperative peripheral retina evaluation during the RRD repair, that is the second surgery, what was noted that missed or de novo breaks were probably the culprit in 11, that is around 69% of the eyes. No break was identified in 2 eyes, 12.5%. GRT, that is more than 3 clock hours of retinal tear, was present in 2 eyes, and one of the patients had a retinoschisis related retinal break. So this table 1 shows the visual outcomes and the details of the macular surgery, which is the primary first surgery. So the primary indication for the surgery was ERM and full thickness macular hole in 8 eyes. The baseline visual acuity was 0.6 logmar units. In majority of the patients, the tamponade used was either air, SF6 or C3F8 gas. Additional procedure in terms of endo laser was done in 4 eyes, and what was noted that the vision improved from 0.6 to 0.4. This was before the diagnosis of the reg-RD, and these patients were followed up over a period of 8.4 months. This table 2 shows the patients who developed RRD post-macular surgeries. So we note that the vision suddenly deteriorated to 1.8 logmar. In these patients, 7 patients had to be, silicone oil had to be inserted in these eyes, and among these 4 patients had even encircling band. These patients were followed up for 4 months. So in total, the total follow-up was 12.8 months for these patients, and subsequently post-RD repair, the BCVA improved to 0.9 logmar. So the anatomical success defined as attached retina after 1 surgery was seen in 14 eyes, that is 87% of the eyes. And the functional outcome, so this is the best corrected visual acuity at baseline prior to the macular hole surgery was 0.6, that is 20/80, and it improved, it worsened to 20/160 at post-RD repair. So these are after 2 surgeries. So we see that among these 16 eyes, 5 eyes showed improvement of 0.5 logmar, 3 eyes maintained the baseline visual acuity, whereas 8 eyes had a loss of vision in terms of logmar unit by 0.8 units. So this is one of the representative figures. Figure A shows the presence of ERM for which the primary macular surgery was done. We see there is a presence of ERM, some cystoid spaces. Subsequently at follow-up, the patient developed reg-RD. Retinal surgery was done. And in figure C, we see the presence of a posterior encircling band. The retina appears attached, and the OCT shows some amount of RPE undulations and attached retina. So coming on to the discussion, we know that multiple mechanisms can be involved in the development of RRD. Among these, the prominent ones are the missed or iatrogenic peripheral retinal break. Some of the breaks also happen post the first surgery, that is de novo breaks, because PVD is not complete in all the macular surgery eyes. So post progression of PVD, and there can also be some amount of vitreous incarceration at the site of the previous sclerotomies. So we note that even though visual acuity improved after RD repair, however, it was still significantly less than the baseline visual acuity. This highlights the role of peripheral retinal examination during the primary macular surgery. So to conclude, RRD post-macular surgeries can happen because of either a missed or a de novo retinal break, and 50%, at least half of the eyes, show a worse visual acuity compared to the baseline despite a successful retinal reattachment. Thank you.
Thank you, Dr. Sumit. Any questions from the audience? Any, Dr. Bhatia, any question?
Dr. Sumit, I
Manisha?
have a few questions. You said it's a multi-centric study, so how many centers have participated? in
There
this?
were 13 centers, one of which is my center where I am working, and 12 were outside India. So it was from Italy as well as from US.
The second thing is that, when you say that the probable cause of the RRD could be the breaks which have been missed, but I would assume that they would cause an RD within 3 months of having done a macular hole surgery.
Yeah, that's why the probable word, because we are not able to ascertain what's the cause, either a sclerotomy related break or the progression of PVD or any other missed break. So etiology wise it's very difficult to ascertain. That's why de novo bar missed break.
Were these cases of macular hole, they underwent a complete vitrectomy or a limited vitrectomy during the first surgery?
So because multiple surgeon and multiple nationalities were involved, so I don't think that all macular hole cases they undergo a complete vitreous based shaving as we do in a
So I think that's a very important factor, because as you also mentioned in one of your slides that probably the PVD induction is continuing to happen after the macular hole surgery. And we would assume, because I don't think any one of us have that experience where we would have encountered an RRD after a macular hole surgery just because there's a vitreous incarceration sclerotomy. I think with MIVS it's become very safe. So probably these are those cases where a complete vitrectomy has not been done, and the PVD continues to get extended and probably results in some fresh breaks. GRT, of course, when we are having a reuse of instruments, probably sometimes we do land up where there is an undue traction in the periphery. But otherwise, I think that could be the only possible reason I can think of if they have not undergone a complete vitrectomy during the primary surgery.
Only interesting thing was like all of these causes will lead to a RD within first 3-4 months.
Absolutely.
So these patients were the ones
PVD induction, of course, can cause it later on as well.
Develop over months.
Dr. Dipinder, I think, have a point to make.
I just wanted to, that intraoperative, I think steps could have been charted, and
Dr. Kanika.
whether PVD induction was done, because some ERM cases have pre-existing PVD, and some cases you induce PVD.
Because this was a retrospective study and 2,900 patients, so it was very difficult to meticulously pinpoint the points like what was done like intraoperatively in all the patients.
Also, I think just one comment, I think I saw your chart and you used SF6 for GRT cases, especially in a recurrent case. I think that's really...
This was one of the US patients, I think.
Yeah, because that's very bold, I think.
Thank you.
Thank you, boss. So Dr. Kanika is next.
Yes. Good afternoon, everyone. I'm Dr.
Dr. Muthu, please come on the next slide. Yes. Dr. Kanika, please continue.
Good afternoon, everyone. I'm Dr. Kanika Godani. I'll be talking about predicting the visual acuity change after a macular hole surgery, a combined model using artificial intelligence, clinical and OCT features. So an idiopathic macular hole is a full thickness defect in the fovea, primarily affecting older females in 5th to 7 decades of life. And the structural disruption is mainly due to anterior-posterior traction from the posterior cortical vitreous, compounded by tangential forces from the ERM and ILM. And this leads to visual symptoms including blurring, metamorphopsia, and mild to moderate vision loss. So the primary goals in any macular hole management are to relieve visual symptoms, improve visual acuity, and achieving successful hole closure. And the current treatment modality is surgical intervention in the form of pars plana vitrectomy with ILM peeling, gas tamponade, and post-op positioning. And the anatomic closure success rates vary from 80 to 95%. So the problem arises when some macular holes do not close after initial surgery. And the two primary challenges that the clinicians face is to select the most predictive preoperative OCT parameter for accurately forecasting anatomical and functional outcomes, and to effectively communicate the likelihood of macular hole closure with visual acuity improvement to patients prior to the surgery. And to address these challenges, machine learning algorithms come into play. So the purpose of this study was to identify the model that delivers the highest accuracy and lowest error in predicting visual outcomes in patients undergoing macular hole surgery, and to enhance precision of outcome predictions, supporting clinicians in both surgical planning and patient counseling. So for this study, we procured data from hospital electronic records to identify cases of idiopathic full thickness macular holes who presented to Retina Clinic in June 2017 to December 2023. And only those patients who underwent macular hole surgery alone with at least 1 month follow-up post-surgery with OCT were included in our study. Apart from that, demographics, visual acuity pre-operatively and post-operatively were taken into consideration, along with high-quality radial OCT scans and, of course, artificial intelligence. All these patients underwent microincision pars plana vitrectomy with complete PVD. ILM peeling techniques, ERM peeling, choice of endotamponade and phase-down positioning were all on clinician's discretion. So preoperative OCT characteristics were documented and measured, and these included attachment or detachment of posterior cortical vitreous over the fovea, presence or absence of ERM adjacent to the macular hole, presence of intraretinal cystic spaces at the macular hole edges, RP hyperreflectivity at the fovea, minimal inner diameter, maximal basal diameter, nasal and temporal slopes of the macular hole, minimum and maximum macular hole height and macular hole area. Post-operatively, so after a minimum 1 month post-op period, the macular hole status was assessed either closed or open depending on according to Krank's classification. For data pre-processing, it was 3 information sheets were generated: a patient information sheet which mainly talked about the patient demographics, ocular information sheet detailed ocular specifics, and image information sheet which detailed OCT measurements. These were qualitative and quantitative variables preoperatively, and postoperatively macular hole status. Now what we did was that these scans which were obtained, we divided into a testing set and a training set in a ratio of 20:80. The training set, from this training set, 6 machine learning predictive models were trained to forecast quantitative dependent variables, that is post-op visual acuity after macular hole surgery, and variables on OCT which were qualitative independent and quantitative independent variables, preoperative. The analysis was performed using the EasyFit function in Excel stat software, applying the following models: ANGOA, random forest regression model, K nearest neighbor, support vector machine, extreme gradient boosting, and lasso regression model. So coming to the results, 158 eyes of 151 patients were assessed. Average age was nearly 65 years. Out of these 151 patients, 61 were male, 90 were females. There was a median gain of visual acuity of 15 ETDRS letters, which is equivalent to 3 Snellen lines. So from these 1665 high quality preoperative OCT images, they were used to provide quantitative and qualitative information about the macular hole characteristics and dimensions. And as I already mentioned, we divided it into 80% training data, 20% testing set to test the previously trained models. So as you can see, if we see the post-operative macular hole status, in the training set and testing set, it's comparable, be it closed or open. The performance metrics of different machine learning algorithms on the internal validation dataset showed that the random forest regression model had the minimal mean square error. And this model identified the post-operative macular hole status as the most critical variable indicator, followed by macular hole index, for predicting the post-operative visual acuity following macular hole surgery. This model also demonstrated predictive accuracy within 1 line of actual visual acuity in 51% of the OCT images, within 2 lines in 72%, and within 3 lines in 83% of the OCT images. This is just an example showing how the machine learning model predicted the status of the post-operative macular hole, either open or closed. So what this study adds, it underscores the potential of predictive models as adjunctive tools, aiding clinicians in post-operative prognosis and surgical decision-making. Furthermore, the study's results are clear, clinically relevant, and readily applicable in practice. Limitations include its retrospective design because of its scope to surgical cases, excluding natural disease progression, and certain surgical factors influencing outcomes such as variability in surgeons, intraoperative dye use, ILM peeling techniques, type of endotamponade, phase-down positioning, and duration of surgery were not accounted for. So in conclusion, supervised machine learning algorithms such as the random forest regressor can accurately predict visual outcomes following vitreoretinal surgery for macular holes. These predictions can reassure patients with a low risk of failure and encourage consideration of advanced surgical techniques in more challenging cases.
However, further validation studies are necessary before this model can be reliably integrated into clinical practice for forecasting macular hole surgical outcomes. Thank you.
Very nice. Thank you, Dr. Kanika. Any questions you have? What's the time for AI now in near future? Or anybody wants to add anything?
So when do you think that this is going to really, I mean, we can have this in clinical practice, and where do you forecast this? And I'm sure GAS is going to be very happy today because we have flowing macular holes everywhere.
This is ready to be used, just that more studies are required to predict its accuracy.
And what would be the, I mean, if we generate this model, how do you see this coming up? And do you, I mean, do you propose to kind of, how do you get it into practice? I mean, you agree that it's ready to use, but then how do you kind of, what is the learning curve and how do you start using it?
So basically, whatever data we have, we take the OCT, preoperative OCT measurements, that is the qualitative and quantitative, put it in a software. And that is where the machine learning algorithms, they produce that result.
So who's marketing the software, and how is it, I mean, who's promoting the software?
The companies.
Oh.
So we use the Excel stat software.
Okay.
That is what we use. It's a paid version.
Right. Thank you.
So next we have Dr. Muthu Krishnan.
Yes, sir.
So he'll be talking on outcomes of surgical management of retained subfoveal PFCL in a vitrectomy case.
Dr. Shweta Singh on the other side, please.
Dr. Shweta Singh.
Good afternoon.
Next
My
speaker.
presentation is on outcomes of surgical management of retained subfoveal PFCL in vitrectomy. Myself, Muthu Krishnan. I'm a consultant at Arund Hospital, Madurai. Subretinal PFCL is a rare but serious complications following VR surgery, and the incidence is around 1%. The toxic effects of PFCL retention are explained by mechanical compression of the retina and chemical toxicity because of the high oxygen carrying capacity of PFCL causing vasoconstriction. On OCT, subretinal PFCL demonstrates an acute angle between the RP and the neurosensitive retina at the base of the droplet. There's an elevation of RP hyperreflective band, RP disorganization, disruption of ELM and ellipsoid zone, and retinal layers above the subretinal PFCL droplets are ill-defined, as seen in this image. So the aim is to study the outcomes of surgical removal of retained PFCL in patients with subfoveal PFCL following vitrectomy. So this is the largest series of cases of surgical removal of subfoveal PFCL, and hence this study. It's a retrospective observational study done at the Department of Vitreoretina at Arvind Hospital, Madurai, over a span of 1.5 years. The primary outcome measured was improvement in corrected distant visual acuity, and we also looked at restoration of foveal contour, restoration of outer retinal layers, and complications. Inclusion criteria was subfoveal subretinal PFCL without any retinal or choroidal detachment, operated by a single surgeon with at least 6 months of follow-up. Corresponding exclusion criteria were maintained. 19 eyes of 19 patients with retained subfoveal PFCL, that was a methodology, over 18 months. Baseline parameters for visual acuity, intraocular pressure, number, duration, and size of the PFCL bubble, and OCT parameters. These parameters are studied at 2 weeks, 3 months, and 6 months with complications. So let's have a look at the surgical technique. The first image shows subretinal bleb being raised, and the third image shows a large bleb raised with, by injecting balanced salt solution with 41 gauge needle. That's the bleb raised. PFCL is injected at the posterior pole, and subfoveal PFCL is displaced using TANOS, and the PFCL is removed by extrusion cannula through a parafoveal retinotomy. The preoperative and postoperative image of patient is shown below. So having a look at the baseline results, so age 54 years, gender 58% male and 42% female. Pre-op visual acuity was 1.8 logmar preoperatively. And indication for primary surgery was 79% regmatogenous RD and 21% tractional RD. The median duration of retained PFCL was 3 days, 1 to 50 days range. So number of PFCL bubbles was solitary in 68% and multiple in 32% patients. Size of the bubble ranged from 270 microns to 1270 microns, less than 500 microns in 2 patients, 500 to 1000 microns in 11, and more than 1000 micron large bubbles in 6 patients. So as we can see in this graph, preoperative visual acuity was 1.8 logmar, and post-operative at the end of 6 months was 0.8 logmar. So this shows a statistically significant improvement in the visual acuity at a post-operative period of 6 months. Comparing duration of retained PFCL with the visual acuity at 6 months, 0 to 3 days retention of PFCL in 11 patients and corresponding to median visual acuity of 0.8 logmar. Similarly, 4 to 20 days retention, again a 0.8 logmar visual acuity was maintained. And when this was more than 21 days retention, there was a mild drop in the visual acuity to 1.1. However, there was no statistical significant difference between these three groups. Restoration of foveal contour was achieved in 90% patients, and there was a localized atrophy of outer retinal layers, as seen in this image, and photoreceptor loss in all patients. Residual parafoveal bubble were noted in 2 patients, and both these patients had multiple bubbles to start with. Complications encountered are macular hole in one and submacular hemorrhage in another patient. So what's the role of OCT? OCT helps to localize the PFCL bubble as well as the multiplicity and demonstrates the dimensions of the bubble, and also helps to differentiate from subretinal fluid or subretinal oil, as PFCL has a distinctive bubble beneath the retina, whereas SRF would be a dome-shaped elevation and subretinal oil is a shallow elevation in a wide area. So several techniques for surgical removal of PFCL. So direct aspiration with various cannulas, or displacement of PFCL and removal with retinotomy, or just a peripheral displacement beyond the arcades without removal. So significant recovery of visual acuity. So what's the ideal timing of PFCL removal, having discussed all this? So significant recovery occurs with PFCL removal as long as 3 months post-operatively. The mechanical barrier effects and the toxic effects may contribute to limited visual acuity. So incomplete fluorination of hydrocarbons during production of PFCL and fibroblastic proliferation is supposed to cause limitation of visual acuity. Perfluorodecalin is more toxic than perfluorooctane. We use perfluorooctane in our study. An important factor is timely surgery. So before I conclude, this is the largest case series of surgical removal of subfoveal PFCL. Significant recovery can be expected till a period of 3 months post-retention. Mechanical barrier effect and toxic effects may contribute to suboptimal outcomes, and the macular status before the primary surgery could also have a bearing on the ultimate visual outcome. Thank you.
Thank you, Dr. Muthu.
Did you try doing a microperimetry in these cases?
No, ma'am, we have not done a microperimetry.
Because probably you could then correlate even the visual recovery with the, effect, the toxic effect of the PFCL that happens when it's in the subfoveal area. Because otherwise it's going to be very difficult to really make a judgment, like you mentioned, that even if till 3 months, because that could just be a physical barrier over there which could be causing a blockage in the visual recovery. But after you've done the removal, did it have any long-term effect on the underlying layers?
Long-term removal, till most of the changes were noted at 3 months, and up to 6 months it persisted.
So next we have Dr.
Thank you, ma'am. Thank you, sir.
Shweta Singh, talking about intravitreal clindamycin in the treatment of toxoplasmic retinochoroiditis.
Dr. Sunil Ganikal on the other side, please.
Good afternoon, everyone. Myself, Dr. Shweta Singh, and I shall be presenting on intravitreal clindamycin as first-line therapy in toxoplasmic retinochoroiditis. So, ocular toxoplasmosis is one of the most common cause of posterior uveitis in immunocompetent patients. It presents as a focal retinitis patch adjacent to chorioretinal scar associated with overlying vitritis. Vision is usually affected with the involvement of optic nerve or macula, or in the presence of severe vitritis. Conventional treatment involves sulfadiazine, pyrimethamine with folinic acid, trimethoprim, sulfamethoxazole tablets, azithromycin, atovaquone have also been used. So I'll be presenting a case series in which intravitreal clindamycin was used as a first-line therapy for toxoplasmic retinochoroiditis. So we report 4 patients of the diagnosed cases, 2 males and 2 females. All patients received intravitreal injection in the dose of 1 milligram per 0.1 ml as a first-line therapy, along with oral corticosteroids, which were tapered over 4 to 6 weeks. So case number 1 was a 40-year-old female. The fundus picture shows active foveal retinitis. Best corrective visual acuity was reduced to finger counting 1 meter. The corresponding OCT shows significant macular edema. The patient got 2 injections of intravitreal clindamycin, and this is the post 2-month picture showing resolved macular edema along with restoration of BCVA to 6/6. Another case, a 12-year-old male who presented with juxta-macular retinitis, best corrective visual acuity reduced to 6/18. This is the post-month picture, the fundus picture, and the OCT, almost coming down to normal. Case number 3, another 52-year-old female presenting with foveal chorioretinitis, best corrected visual acuity reduced to finger counting half meter, with significant macular edema and retinitis, as shown in the fundus picture along with OCT. This is the post 2-month picture showing almost resolved retinitis patch and foveal contour restoration. Another case, this is a 22-year-old male who presented with a macular sparing retinitis patch. This is the picture post 1 month. So why and where to use this intravitreal clindamycin? Because high concentrations are reaching, it has a direct action on the target site and there is no systemic side effects associated. Where they can be used? In presence, if the patient has allergy to the systemic medications like sulfa-containing medication, in presence of intolerance to the oral medications like pyrimethamine can cause leukopenia or thrombocytopenia, when patient is intolerant to oral clindamycin with associated risk of pseudomembranous enterocolitis, wherever we are experiencing worsening or no improvement despite systemic medication, or wherever there is non-availability of pyrimethamine. Also, literature has also supported the use of intravitreal clindamycin. We came across few studies in which dexamethasone was also used, but in our patient we used only oral steroid in the dose of 1 milligram per kg per day. Then, conclusion, intravitreal clindamycin is equally effective for toxoplasmic retinochoroiditis. It is safe, efficacious, it has got better patient compliance and improved systemic safety profile. It has enhanced availability at the target site. We need lesser follow-up visits and less hematological investigations, and it can also be used as a better choice for treatment in pregnant females and pediatric patients. However, clinical studies are needed to validate the efficacy and safety in such age group and in pregnant females. A word of caution, we came across 2 cases in which they have reported the macular infarction, which was an aminoglycoside-like toxicity, which occurred in patients with intravitreal clindamycin as a treatment. So we recommend timely review and follow-up to detect any early signs of worsening. Thank you.
Thank you, Dr. Shweta.
Thank you, sir.
Any questions anybody has?
So we know that it responds very well to intravitreal clindamycin. Why we all prefer combining it with systemic therapy is that there's a very high chance of recurrence. So that is the main purpose of giving it, and that is why as a first line, of course, for macula involving lesions, it's very much the first line of therapy. But in the long term, we have to be careful that a recurrence rate is very high.
Well, ma'am, these 4 patients are in a regular follow-up. We haven't came across any recurrence in these 4 cases, but yes, whenever we are planning intravitreal clindamycin, patients should be asked to come in regular follow-ups.
And another important indication would be a pregnant female, where
yes.
systemic therapy is contraindicated.
Yes, ma'am. See.
So how frequently did you give the intravitreal clindamycin between the patients?
Sorry?
How frequently did you give? Like it was a single dose or 2 or 3 doses were given?
Sir, this was a case series. We gave 2 doses. The duration between the 2 doses were 1 week, and after that we are following. We don't give as frequent. If the patient is tolerating the oral therapy, then we continue with the oral therapy.
And how long was the oral steroid given?
So oral steroids were given for at least 2 months, around 6 to 8 weeks for all the patients.
Can we combine this intravitreal clindamycin with dexamethasone?
Ma'am, in our series we haven't, but yes, we came across few case reports as well as a large series in which they have used dexamethasone. But we did, because we have to support the patient on steroids, so we gave oral steroids.
So the recurrence of toxo doesn't happen in every patient, but when it happens, it can be very bad. And sometimes there's also a description of a prophylactic or a maintenance dose of clindamycin, which can be given to the patients, and they may be requiring a treatment even for a year or longer.
Okay.
So that is why I think systemic therapy is equally important as much as is the intravitreal injection.
Noted, ma'am. Thank you so much.
Thank you, Dr. Shweta. Now the last speaker is
He's absent.
Dr. Sunil. I think he is not
He's
there.
not there.
So with this, I conclude, and I thank you all my co-chair Dr. Manisha, Dr. Priyank, Dr. Ashish, Dr. Avdesh and Dr. Gagan Bhatia. And we all please come for the photograph.
Thank you, sir.
All the speakers can come for the photograph, those who are present.